In sinoatrial blocks, or sinus blocks, the SA node conducts P waves normally until a P wave is missed and a complete electrical cardiac cycle is not conducted. This is seen on this rhythm strip as a long pause. The last wave on the EKG before the pause is this QRS complex seen here, without subsequent following P waves, which leads us to believe that there was no atrial depolarization from the SA node, and as a result, failure to conduct another cardiac cycle. This is a classic example of a sinus block, where normal sinus rhythm is presumed after this long pause, at a rate typical for the SA node. You could tell this rhythm is sinus before and after the pause, because the P waves have the same morphology in every cardiac cycle, which are then subsequently followed by narrow QRS complexes. This is slightly different than what you could see in sinus arrest. That's because in sinus arrest, this long pause is reflective of the complete failure of the SA node to produce or transmit electrical impulses. In other words, the SA node just doesn't produce any more action potentials, and therefore no more cardiac electrical activity, until another electrical focus within the heart takes over. As a result, this pause may be longer, and eventually, the heart will conduct a beat that is not sinus. Unlike in sinus block, where the pause is followed immediately by a P, then a QRS complex, in sinus arrest, the heart will continue to pause until another automaticity focus kicks in. In this case, you won't see the typical P, QRS waves seen in normal sinus rhythm. This is the result of the heart's ability to overdrive suppress itself, when its inherent automaticity focus fails to conduct cardiac action potentials. Let's take a side note here. Overdrive suppression is the heart's ability to replace an area of electrical automaticity with a faster pacemaker. In this case, when the SA node fails to pace, which it does normally at approximately 60 to 80 beats per minute, then a junctional pacemaker takes over, since it's the next fastest automaticity focus, pacing at about 40 to 60 beats per minute. In this case of sinus arrest, when the SA node fails to conduct more action potentials, the heart overdrive suppresses itself by conducting electricity from the next fastest focus, which is the AV junction, producing a junctional escape beat, seen here. Notice that this QRS complex is not preceded by a P wave. This is classic for a junctional escape beat because electricity does not originate from the atria. Instead, it originates from the AV junction and conducts down to the ventricles. If it weren't for the heart's fail-safe ability to find a new pacemaker, cases of sinus arrest could continue to have longer and longer pauses, and even asystole, until the SA node decides to conduct again. These types of arrhythmias occur when the SA node fails to either produce another action potential or fails to transmit action potentials from the SA node down to the normal conduction system of the heart. It would be helpful to know that the SA node is made up of core cells, which produce electrical activity, called P cells, and outer transition cells, called T cells, that help transmit sinus impulses out of the right atrium. Failure of the P cells would lead to failure of the SA node to produce electrical activity, and as a result, lead to sinus arrest. While failure of the T cells would mean that the SA node still produces action potentials, but has a difficult time transmitting it to the rest of the heart. Some experts believe that this inability to transmit action potentials from the core to the rest of the heart is what leads to sinus blocks. So in sinus blocks, there is a pause, followed by normal sinus rhythm resuming normal cardiac conduction. Whereas in sinus arrest, the pause is followed by electrical activity that is an escape beat from another automaticity focus, in this case, a junctional escape beat.